Okay, this session will be a hot topic regarding brain protection or not. We will have 3 lectures in this session. The first one will be delivered by Dr. Xianbao, Cerebral Embolization after TAVR, presented on behalf of Professor Liu by his colleague, Dr. Zhu. Rajesh Kharbanda, Professor, can you hear us?
Good morning. I am with you. Can you hear me?
Yes, very clear. Would you please start your talk first, and we may have a discussion later. Please.
Yes. Good morning, everybody. Thank you for the very kind invitation. I will share my slides. Can you see my slides?
Okay, we can see it.
Excellent. Well, thank you for the very kind invitation. So the topic of my talk is Cerebral Embolic Protection, and I'm going to focus on the recent data and future advances. And I'm from Oxford in the United Kingdom. Thank you. So I'm going to cover 4 real questions. Firstly, how frequent is stroke in TAVI, in modern TAVI? What is the impact of that stroke? And then how might we reduce strategies to reduce stroke? And what are we looking toward in the future? So this slide shows you the reported incidence of stroke from randomized trials. And what you can see is that there is quite a marked variation in the reported stroke rates, ranging from less than 1% to up to 9%. And the real reason for this is because it depends on how you both measure stroke and how you define stroke in these trials. But a figure of between 2 and 4% seems to be average here. There's been no major reduction in stroke incidence over time, and that's quite important. So trials are one way of looking at stroke. This is data from the UK TAVI registry, and national registries are an important way to understand what's happening in real-world practice. And there are 2 points I want to bring out from this study, from this slide. One is that stroke incidence has gradually reduced, but not majorly reduced over time, and still remains significant at about 1.6%. So self-reported stroke is about 2%. And we can talk perhaps about the differences between trial-reported and self-reported stroke. But the 2 points I want to bring out are stroke frequency depends on how hard you look for stroke in your patients and what definitions you use. So if we see major stroke, it's easy for us as cardiologists, but minor stroke is much more difficult to detect, and it depends on what definitions you use. So I think the frequency is about 2%, but that is dependent on how actively you look and measure it. Turning now to the impact of stroke. This is an analysis of nearly 72,000 patients. And so this is 1,000 patients having a stroke. The incidence now about 1.6%. This is similar real-world registry data. And what you see on the right is patients who either received medical treatment, the vast majority, 90%, a small proportion received thrombolysis, and a small proportion thrombectomy. Look at this, about 4%. The vast majority are treated medically. And in these patients, the mortality, the inpatient mortality rate is still very high here, ranging from between nearly 10 to 20%. So stroke is frequent, 1.6%, and carries a high mortality. There's all sorts of selection here about patients having different treatments. This is in-hospital mortality. If we turn now to longer term outcomes, and this is looking at both 3-month and 1-year outcomes, you can see in this study of nearly 16,000 patients, a rate again of just around 2%. About half of these are large strokes if you characterize them by the NIHSS score, patients lose their independence related to the severity of the stroke, but even those with a minor stroke, 60% of them are independent, meaning that nearly 40% are not. And large strokes really are associated with this gradient of later death. So this is not this is a serious outcome for these people. So moving now on to quality of life. This is a study looking at the quality of life. This is not in TAVI stroke, but in strokes in general. And the red line here is what people characterize as the quality of life, and death has been marked as 0. And many patients with disabling stroke rate their quality of life after stroke as lower than death. So this is a really important thing for patients, that they often find stroke and disabling stroke much more impactful on their quality of life. And that's an important thing for us to consider. So it increases mortality, it causes a loss of independence, it increases costs, and it impacts on patients' quality of life. Okay, turning now to what we can do to try and impact on stroke. The vast majority of TAVI-associated stroke is embolic. Global ischemic stroke following cardiac arrest during the procedure is very rare, and hemorrhagic stroke is very rare. And there's been some investigation of whether this is related to traversing the arch with devices, deploying the device, or pre and post dilatation. But if you do cerebral Doppler, actually the signals are throughout these aspects of the procedure. So there's no specific procedural time at which emboli occur, but we know that the vast majority are embolic in nature. Some of this is related to patient factors. Some of this is related to procedural factors. And here I've tried to illustrate some of the things that might be important. So we know that the transfemoral route is least associated with the risk of stroke. So if you're undertaking axillary procedures or subclavian procedures or aortic procedures, the risk of stroke is higher. Now, understandably, we're doing those procedures in patients where femoral access is not possible. They have advanced vascular disease. It might be something to do with the complexity of the aortic arch. And in truth, we haven't really looked at that in any detail, and there isn't much information about that. It may be to do with the heart valve you use, and the device or the delivery system may have different aspects that may predispose to more interaction with the aortic arch or challenges deploying the valve. There are a number of procedural factors that might be relevant. And in addition, we really are testing the use of embolic protection devices in this talk. As you know, there are a range of embolic protection devices available, many of which are in an early stage of investigation. Some of them deflect, some of them capture, but the most widely available and tested device is the Sentinel device, which consists of 2 filters deployed in the left carotid and the right subclavian artery. And that is available both with European and FDA approval, globally used. It's a right radial access, it's 140 micron size, and it's 6 French radial access. You all have your album of these sorts of pictures where you take out the device and you see these amazing debris that is collected by the device. And so the device certainly collects debris. And the question has been, does this translate into clinical benefit? So turning now to recent data that's been presented, we presented the results of the BHF Protect TAVI trial at the ACC in this year. And that trial was 7,500 patients. And that trial complemented the previous trial testing cerebral embolic protection, which was the protected TAVR trial. And just last month, we presented data from the combined data set of 10,000 patients. So here is a summary slide of those two large randomized trials testing embolic protection as a routine strategy. Remember, these patients were not selected on the basis of any characteristics. This was routine use of the device. On the left, 3,000 patients in protected TAVR. Those were across 51 sites in the United States, Europe, and Australia. And on the right is the British Heart Foundation Protect TAVI trial, which included over 7,500 patients, all from the United Kingdom. And what you can see is that the stroke rates in the protected TAVR trial and in BHF Protect TAVI were both around 2%, and there was no reduction in overall stroke with the use of a routine strategy. There was this signal to disabling stroke that came out in protected TAVR with a significant reduction, but this wasn't powered. And in our trial, a numerical reduction, but no significant reduction. So how do we take this forward? Well, we undertook this individual patient-level meta-analysis. As I've said, over 10,000 patients, now 5,000 patients in each group. And the key outcome is published here, showing that for all stroke, there was no major reduction. But for disabling stroke, there was this tendency to a reduction in disabling stroke. The p-value here is 0.09, and the confidence intervals are wide. So there's no evidence that a routine strategy is effective in reducing stroke. Well, what about some of the secondary analyses? And this is relevant because in some patients, even when you try and deploy the device, either you can't reach the vessels or the device has to be removed because the patient has a complication. And in the trial here, nearly 800, just over 800 patients didn't have the device in, both filters, for the whole duration of the procedure. Now, there are a number of reasons for that, but we want to try and understand whether those patients are different and how that drove the result. And there are two ways you can do this. This new statistical test called Complier Average Causal Effect, many of you in the audience won't know or recognize that, but the key issue of that is that it maintains randomization. And then what we're familiar with, which is the per protocol analysis, i.e. look at the patients in whom you could deliver the device. The problem with that is that the reasons why patients don't get the device are very important and may relate to why the device can't be delivered is actually that they have a high stroke risk. It's the complex carotid. It's the complex patient with complicated anatomy. And the device itself may be irritating and cause events. Nevertheless, these are the sorts of analyses that we can try and use to compensate for non-compliance with treatment. And what you see here is a statistical reduction in per protocol treatment, and we've talked a little bit about the issues with per protocol. And when you adjust, you lose some of that significance for age and sex. But turning now to disabling stroke, we see that the frequency of stroke is lower, but nearly significant. But when we look at the per protocol analysis, there is a reduction in stroke. And even after adjustment of age and sex, that reduction remains. But remember, this is a secondary analysis. So there's no reduction in stroke if we use it in everybody. If we use the case analysis, we don't see a reduction, but the per protocol analysis shows this signal toward a reduction in disabling stroke. And that is where, when it's fully deployed. So turning now to subgroups, this is the publication of trying to tease out whether there are particular subgroups where embolic protection was effective. You can see on this slide that there are no easily identified subgroups. There are some tendencies, such as in the self-expanding group, such as in older people, where embolic protection may be more effective, but none of these reach conventional statistical significance. So what might we do in the future going forward? So if we look at BHF Protect TAVI, and this is another way of looking at the data, this is really looking at the impact of sex, of valve type, of post-dilatation. We begin to see that there are some groups that have a higher stroke incidence. And in this series, nearly a 1% difference in the incidence of stroke between these groups. Now, we don't know the interaction. For example, we know that females are more likely to get a self-expanding valve, and self-expanding valves are more likely to be post-dilated. So we don't know the individual contribution of this to the groups, and that's work we need to do. But this may tease out subgroups. And as we go forward, what we want to try and do is to develop a risk score and identify who is at highest risk, examine if there are groups who may benefit. And in addition, that first slide I showed you about thrombectomy or medical treatment, we actually need to understand which are the best treatments for stroke. So in summary, TAVI-associated stroke remains an important complication. The embolic protection devices may be effective in reducing disabling stroke, and we need to understand that. And we need to understand who is at higher risk of stroke and where CEP may be most effective. Thank you very much, and I'm happy to take questions.
Maybe we can go through all the talks. Okay. Dr. Zhu?
Yeah, I can hear you.
Okay, thank you. Please present your data.
Okay, thank you. So because Professor Liu is still on live demo, I will be the representative speaker of his speech. So maybe I will use, I will try to give this speech in Mandarin. Can you see my slides?
Yes, please.
Okay, thank you. 尊敬的院长，各位与会的嘉宾，下午好。因为前面这个给到我们的题目呢是这个脑保，就是一个 TAVI 术后的一个脑栓塞事件。那么我们这个患得呢，要从这5个方面来讲。其实前面坎班达教授已经提到过很多内容了所以他提到的部分呢，我们就简单过一下。包括这张片子，我们看到就是随着这个 TAVI 往这个低危的方向、低危的人群去拓展呢，脑卒中仍然是一个非常重要的一个并发症。虽然说它的事件率已经逐渐在下降了，但是我们看到，即使在低危人群、低龄人群当中呢，仍然是有相对来说比较高的一个发生率。那么80%以上的这个 TAVI 相关的脑卒中事件呢，其实我们看到都是发生在 TAVI 术后的短期。那一般来说，在术后1周以内呢，绝大多数的这个卒中事件都发生了所以包括在我们中心也是绝大多数的卒中呢，我们往往是在住院期间看到的。当然卒中这个事件呢，它本身跟预后是明确相关的。像这一个1万多例的一个队列里面呢，我们可以看到，卒中事件它会和术后30天的一个死亡率呢是成一个显著相关。它的 OR 值达到了6.0。当然非常有趣的一点呢，就是对于这个卒中事件呢，它跟这个术者的经验和这个中心的一个手术量呢，并没有一个明确的关系。那我们看到在17年的 Jack 上面有 TVT Registry 它的一个报道，一共有4万多例商业化的这个 TAVI 的病例一共有将近400家的医院但是我们看到呢，就是不论是大医院还是小医院，还是说这个术者的经验丰富，还是说这个新手脑卒中它这个事件呢，就是呈一定的比例发生的。 当然第二块内容呢，我们要讲一讲这个 silent stroke，silent stroke 其实是近几年来，包括开始做脑保护装置以来，大家都非常关注的一个问题啊。往往大家都认为呢，卒中是对临床真的有影响的。但事实上 TAVI 术后呢，有一大批患者呢，他在这个磁共振上呢有 DWI 的一个高信号，有这个栓塞事件但是呢，他在临床上呢没有任何表现。那这种呢，我们会认为是一个 silent stroke，brain stroke。那我们看到就是在这个各大临床研究里面，stroke 它的发生率呢其实并不高，但是它会跟这个预后明显相关，会导致30天的一个死亡率显著增加但是这个 silent stroke，隐匿性的这些脑卒中呢，它的发生率会非常的高。那么根据已有的几篇研究报道呢，我们看到这个不论是 PCI、CABG 这些非瓣膜手术，它的发生率呢一般会在10%到20%左右。但对于换瓣手术，外科换瓣手术呢，它的发生率往往在50%左右。而 TAVI 手术呢，由于它的这个本身这个器械的这个特性包括我们术中的像球囊扩张的一些操作呢，术后的一个隐匿性脑卒中的发生率呢，甚至可以达到80%以上。当然，它跟预后呢，目前没有找到非常明确的关系。但是我们看到呢，它会跟我们的这个情绪上的一些改变、认知功能上的一些改变，包括患者生活质量上的改变，会有一些相关。那么，这个就是在很多这个研究里面会放的一个图，就是其实脑卒中它还是呈现一个非常有趣的一个规律的，从大的这些临床有意义的卒中，到这个隐匿性的卒中，认知功能的损害其实我们发现，我们有不同的一个评估手段，就会得到不同的神经事件的一个发生率啊。那么在近期的一些这个研究里面，我们也看到了，其实隐匿性的脑卒中 （silent brain injury） 它的发生率是非常高的。在部分这个研究里面尤其是做脑保护装置的，它的研究里面呢，甚至发生率高达100%。那么目前我们针对于这个脑保护也好，或者说脑损伤、脑卒中也好，我们目前最常用的还是根据一个大脑供血动脉进行一个分区，往往把它分成这个前动脉、中动脉和后动脉这样3个供血区来评估。那么这个也是我们20年发表在 Jack 上的一个单中心的研究。那么在这个研究里面呢，我们对比了这个2叶瓣和3叶瓣病人他的一个脑损伤，他的一个隐源性脑卒中的情况。那么在这个研究里面呢，我们看到，似乎这个2叶瓣的病人呢，他会比3叶瓣的病人呢，会更容易出现一个隐源性脑卒中的情况所以在当时那个研究里面呢，我们也提出来了，是不是2叶瓣的病人会不会更加需要一个脑保护装置？那么我们也看到，就是前面 BHF 这个研究里面，它其实有一部分回答了我们的问题，因为我们看到在它的亚组分析里面是包含了这个2叶瓣和3叶瓣的一个分析的。那么对2叶瓣病人应用脑保护装置呢，可能并不会降低一个主要终点事件的发生率。那么在前面研究基础上呢，我们也进一步去探索了，这个对于这些病人他的一个认知功能的一个变化情况。那目前呢，我们是对这些病人呢进行了一个长达3年的一个认知功能的一个随访。那我们看到一个很有趣的趋势，就是在术后1年左右呢，这批病人往往会在1年左右的时候呢，会有一个显著的一个认知功能下降但是在术后长期的阶段呢，他的这个认知功能呢，基本上又会恢复到我们基线的一个水平。那么对这些病人再进行一个亚组分析，我们就能发现，对那些基线的认知功能比较差的病人呢，做 TAVI 呢，它似乎是能够改善这些人的认知功能的。他在术后1个月、2年，再到3年，这样的时间上呢，他的认知功能都比基线会有一个相对来说比较显著的提高。而对于这个认知功能正常的病人呢，似乎我们看不到这个现象。那这也可能归咎于本身 MMSE 这个量表，因为我们中心是用 MMSE 来评的这个量表它本身的天花板效应在那边。 所以基于这个问题，我们也在思考，就是如果碰到了这个评估认知功能的一个瓶颈，像比如说天花板效应的情况，那下一步我们应该怎么做？那其实我们这个时候，我们采用了一个方式，就是去做分维度的量表，去做更加复杂的一些认知功能的量表，去把这个问题给它研究清楚，到底这些病人的认知功能在TAVI术后是升高还是下降的？当然，除了我们之外呢，国际上也有很多研究者在做这项工作。从最早的2016年的这个魁北克医学中心的几位教授，他们就提出来了，这个 TAVI 术后的认知功能呢，应该还是改善的。那么他们呢，就用了非常详细的一套除了 MMSE 和摩卡之外的一些复杂的认知功能量表进行了评价，对我整个认知功能的6大维度都进行了一个很详尽的评价。那他们看到呢，的确是认知功能有所提升的。那同样的，在今年的这个 eClinical Medicine 上，这个是来自荷兰的这个 Capita 研究，它的研究方法呢也是类似的，它评估了这 TAVI 术前和术后的认知功能，并且呢去监测了一个 TAVI 术后的一个脑血流的情况。那同样的，他看到了，就是说对于这个TAVI 手术，在术后3个月，它似乎是认知功能都是有一定程度的提升的。那么再来到我们自己中心的数据，那这是我们自己中心做到目前的一个数据啊。那可以看到，我们用了非常多的量表，除了 MMSE 之外，还用了 DST、AVLT、TMT、BNT 等等，去评价每个患者他的不同的维度的一个认知功能。那总体我们看到的趋势呢，就是不论在哪个量表上面不论是它的一个执行功能，还是说计算功能，还是说它的一个逻辑功能，或者说回忆功能，似乎是都有一定程度的提升的。每一个领域它随着这个时间变化呢，都是有统计学显著意义的提升的。当然这里要考虑到，就是说虽然这些量表它没有这个天花板效应了，但它有一个问题就是练习效应因为这些量表它的这个评价方式相对来说会比较单一所以患者他在不断的做这个量表的过程当中呢，得到了练习，也可能会导致他的这个成绩提高。那么第3块的话就是一个这个 silent stroke 它的一个预防和管理那么前期呢有一个 ADAPT 研究，我想大家都很熟悉了。这个研究呢，它针对的就是这个它瞄准的就是 TAVI 术后的一个隐匿性脑卒中的这样一个事件，那么去评估。对这批病人，采用抗凝还是抗栓不同的方案，会不会影响这个磁共振上的这个隐匿性脑卒中的一个数量？当然结果还是阴性的。在这个研究里面呢，他们并没有发现两组之间用抗凝或者抗栓之间的一个明显的差异。那另外一块呢，就是一个脑保护装置前面的讲者其实已经提得非常仔细了当然我们也看到，就是说目前其实市面上的这个脑保护装置呢是非常多样的目前我们大陆呢能拿到的就是一个 TriGuard 3这一款产品目前呢我们自己中心做的是不多我们也还在观望当然这方面的研究也非常多了，我觉得我在这边可能就不再详细展开了包括像 TriGuard 3它的这个 Reflect 研究，其实它做出了一个相对来说比较好的结果他认为采用这个脑保护装置呢是能够有利的包括这个Sentinel 的一个 Protected TAVR 这个研究是由美国主导的一个研究。那我们也看到了，就是在这个主要终点，尤其是这个 disabling stroke 致残性卒中上呢似乎采用脑保护装置呢能够获得一个比较好的一个获益。当然我们要知道，它在这个主要终点，在这个所有卒中事件上呢，它并没有取得一个比较好的效果包括像这个前面教授分享的这个 Protect TAVI 研究，其实也是一样的，就是得到的往往更多的是一个阴性的结果。那我们也看到，就是在有一些真实世界的研究里面呢，也有一些类似的研究但在这些研究里面呢，我们能看到，似乎脑保护装置它是有用的它能够降低这个缺血性卒中的发生率。当然，这可能跟我们本身患者选择也会有关系因为采用脑保护的患者，我们往往会选择那些相对来说的确是卒中高风险的患者这也是真实世界和随机对照研究它存在差异的一个主要的原因。也有一些研究去关注了这个 在2叶瓣患者当中采用脑保护装置的研究的一个结果，这个是23年发表在 JAHA 上的一篇文章。看到似乎这个采用脑保护装置呢是能够帮助2叶瓣患者去减少这个脑卒中事件的。那不论是这个所有卒中事件还是缺血性卒中事件呢，采用脑保护装置都能够减少一个事件的发生率。那么最后简单做一个总结，就是其实目前来看呢，不论是这个国际上还是我们这个亚洲地区呢，其实TAVI 术后的一个脑卒中呢，它还是比较常见的一个事件因为这个统计强度的不同呢，它发生率可能会有比较大的差异，有比较低的，也有比较高的但总体来说呢，只要TAVI 术后出现一个这种显性的卒中事件呢，它还是会影响到一个生存率的。那第二呢，就是本身像这类事件呢，它可能跟这个中心的大小或者跟这个术者的经验呢关系不大当然我们特别要关注的就是一个隐匿性卒中，一个 silent stroke 或者我们叫 covert stroke 这个事件它呢是非常常见的TAVI术后比较常见的一个事件。目前我们的发现呢，似乎跟这个严重的钙化或者跟2叶瓣的病人呢会有一个明显的关系但是呢，目前采用这个抗凝或者抗栓的方案呢，似乎都不影响这个事件的一个发生率，它更多的可能还是术中操作的一些影响。目前的几大这个临床研究，我们看到的呢，似乎这个脑保护装置呢，它可能并不能降低临床卒中的一个发生率但是它可以降低一个隐源性卒中的发生率。好的，这就是我的分享，谢谢。
Let me briefly report our single center experience on cerebral protection. As mentioned by Dr. Kharbanda, disabling stroke is the number one fear of patient undergoing TAVR, greater than the fear of death. So actually, as shown, the outcome of major stroke after TAVR is really bad. So we should take these things very seriously. So Sentinel is the most widely used device until now, and it was approved in the US, Europe, and in Taiwan. So from the previous two large studies, the favorable trend of reducing disabling stroke in both trials are not negligible, although it was seen to be insignificant in the BHF trial. As mentioned also by the previous distinguished guest speaker, in the meta-analysis of these two trials, only disabling stroke have been shown to have been significantly reduced by per protocol analysis. So we analyzed our own data. In our center, we routinely do cerebral protection. We think it is safe and can be successfully deployed in more than 95% of patients without complications. We started a program 2 years ago, and we have done 202 cases, 118 SEV, and 84% BEV. The first question is that, does the type of THV affect the amount of size and the size of the debris captured by CEP? We divide the particles into 3 categories: smaller than 2, 2 to 5, and larger than 5 millimeter in size. We use this cutoff because the cerebral arteries were in the range of this particle size. We showed that in our first analysis of 74 patients with a pathology report, all patients had visible debris, predominantly valve tissue, calcification, and thrombus. And a significant difference was observed in particle counts and the particle size greater than 5 millimeters between the SEV and the BEV groups. Logistic regression analysis revealed that the patient who received SEV had a 16 fold increased likelihood of having captured debris larger than 5 millimeter compared to those who received BEV. Recently, we further analyzed our total number of 202 cases. We still found similar result. That means larger particle is significantly higher incidence of capture larger debris in those patients underwent self-expanding valve deployment. Furthermore, this was related to the reposition time of the self-expanding valve. That means if we recapture the valve for 2 times or 3 times, you can get more debris by the captured by the cerebral protection device. We also analyze bicuspid versus tricuspid because, as mentioned in the previous lectures, bicuspid seems to have significantly higher instance of stroke. This is the patient groups. We have SE patient put in bicuspid in a small number of 13, and the SEV in tricuspid aortic stenosis in 106. And we put BEV in 17 BAV patient and 16 tricuspid patient. The results have shown that there are smaller, higher incidence of capturing smaller particles in the bicuspid group, but no difference in the large particle. We further analyzed the different valve devices, similar finding to the previous one. Larger particles were captured by those underwent TAVR with self-expanding valves. And also, retrieval time and the reposition time of self-expanding valve in such a small number group still show significant difference regarding the reposition times and the particle size. So in conclusion, it seems that we should tailor THV choice based on individual patient anatomy, clinical profile, and the stroke risk. We should minimize repositioning in patient undergoing TAVR with self-expanding valve. So this should be cautiously done. The operator should be patient during the procedure. And furthermore, selectively employing CEP in high-risk patients, such as those with bicuspid, with undergoing TAVR with SEV, can maximize the clinical benefit. In my opinion, up to now, and also some of our heart team members also think that many physicians argue that CEP should not be used routinely unless it is proven to be beneficial of a specific subset of patients. However, I think that if there are patients who could benefit from CEP use, why completely avoid using it just because we have a negative trial? Current evidence suggests that routine use of CEP to prevent stroke is not recommended. We agree. However, the key challenge is that we still do not clearly know which patient will truly benefit from CEP and which will not. Since it is highly likely that some of the patients may reduce their risk of disabling stroke with CEP, then as long as the patient can afford it, why not using it? So to me, it is just about money. The decision to use CEP is primarily an issue of cost, not risk tolerance. I thank you for your attention. So maybe we can have a 10-minute discussion. Dr. Kharbanda, are you still there? Thank you.
I am, yes.
Yeah.
Thank you.
We have distinguished panelists here. And any comments?
Yes. Can you hear me? Yes. I'm Dr. Chae from Seoul, Korea. I have a question about the future, the improvement of the cerebral protection devices, because right now the Sentinel device is the only one device available in Korea. But I think this device itself can make embolic stroke during the procedure, and also the 150 micron size is not perfect to protect all the debris from the aortic valve. And also the filter loop cannot be completely occlude the vessels. So that might be the etiology of the debatable outcome data about the cerebral protection device. So do you have any idea about the improving the cerebral protection device? And also, finally, it cannot cover the left posterior circulation also. So what do you think about that?
I think those are good points. This, remember, was a first-generation device, and like many of us in interventional cardiology, devices improve and change over time. So that is an important point, and the 140 micron filter size is relevant. So all of those things are true. I think any device needs to be easy to use, have safety, and not, have additional vascular access issues. And many of the other devices are being tested, have some advantages. I agree, the deflectors, but from what I've seen, none of these are much easier to use. They all have similar either vascular access issues or other complexities where you're placing the device. So the ideal device is still to be developed, I think. But the Sentinel is widely used. There's a lot of experience with it. I do agree with you that in some patients it may be contributing to events, but we don't know that, and that's part of the problem. And it's about selection, and it's about experience and training. You make good comments, but those are true of most interventional devices that we use.
I have a question to Dr. Yin. And so congratulations for your data about the Sentinel device in your hospital. And I have two questions about the sex difference, because the female is more higher tendency to have a stroke, but in your study, the male patient had higher size of the emboli. Is it really correlated to the stroke rate? The sex differences. And the second question is why in the bicuspid, the TAVR procedure, the particle size is smaller than the tricuspid valve?
Well, I personally think that because male patient has more advanced atherosclerotic disease, as mentioned, the valve tissue get more severe calcification, and also the atheroma on the aortic wall may have some organized thrombus there. So it might be the reason. And regarding the calcification and the procedure, I think it should be something to do with that, making the differences between these. Because as we know, the bicuspid usually have asymmetrical calcification. So valve crossing or deployment or resheathing might scratch down some small debris captured by the CEP. You want to make some comment?
Yes, my comment is because I have a question for Kharbanda, and also we routinely use the CEP in our center. And we have 2 cases of the stroke after CEP, and we do the MRI. All the patients are the posterior circulation. So that's most of, usually that's the cerebellum and the occipital areas, multiple emboli over there. So that I think that my question is, do the trial check the MRI and compare that the embolic stroke came from the anterior circulation or posterior circulation?
So no, the trial did not routinely mandate MRI. You know, we had 7,500 patients, and routine MRI was not done. It just wasn't practical or cost effective. So the other to make is that if you do MRI, as has been shown, many of these patients have MRI lesions. Whether those lesions, but clinical stroke is much less. So I think that's an important distinction for the audience to understand in terms of that. In terms of the kinds of strokes, I think we're beginning to understand this hypothesis that there may be what we now call sort of type 1 stroke, which is large embolic material. And, that's been shown that a large embolic is different to microemboli. And certainly we're looking at some of these scans and seeing that the events that occur in patients who had successful embolic protection device, there's often a shower of smaller emboli, which, as has been said, may either be going through the filter or around the filter. So there are probably different mechanisms of stroke, and perhaps the device deals with large embolic debris rather than the microemboli. But your point about the posterior circulation is important. And also remember that many of these patients don't have an intact circle of Willis, so even these patients, it may be more to do with how they tolerate these events and their brain reserve rather than the actual location of the embolus. But in answer to your question, MRI, no, it wasn't done routinely.
Dr. Zhu, 你们的研究我看有很多做了 MRI. I mean, you have done many MRI after TAVR, with or without cerebral protection. Do you have any significant finding or differences between the 2 groups? And the second question is that the brain circulation seems to be improved by TAVR itself. This may improve neurocognitive function afterward. And does this mask maybe a smaller decline of the neurocognitive function because of the shower of the debris? Oh, he's not online now. Dr. Kharbanda, do you think this is
yeah, we've done some. Neurocognitive function is very difficult to assess. Most of these patients, remember, are in their 80s in our population. I don't know if you're treating younger population in Taiwan, but so neurocognitive function is a very difficult assessment, and some of the detailed tests that have been shown are very difficult to administer. We have done some neurocognitive assessment. We've used the MOCA score in over 3,000 of our patients, so we've got quite a large data set. The average MOCA score did not change. There is a learning effect, remember, so there are some subtleties that we need to understand. But I completely agree with you that as we're moving into treating younger patients at lower risk, that perhaps there is something to be said for understanding neurocognitive function and brain protection in a wider sense. I agree.
So last question, maybe you can make this as closing remarks. After the 2 large trials, many centers stopped using CEP. And how about your center? If the anatomy is feasible, the procedure is smooth, and the patient is willing to pay, will you routinely use it or not?
Yeah, so look at this. You've raised the important question of which healthcare system you work in. I work in a national healthcare system. My patient can't choose to pay. So we have a system where we deliver guideline-directed evidence-based medicine. And in our system at the moment, because of the neutral trials, there is no mandate to, or there's no structure for me to deliver embolic protection. I agree with your points that there are high-risk patients where it may well be of benefit. And until we can get that information, we are restricted. But that's why I want to get that information. And I think it speaks to a little bit about the healthcare system and your geography. Remember, your patients are probably slightly different. I was visiting the region recently, and I was surprised by the number of young bicuspid valve. It's a different condition, and the use of self-expanding valve technology is more locally in your region. So I think it's hard to extrapolate what to different populations necessarily, and perhaps different diseases. So the point I'd like to make is that it depends on your geography, depends on your patient mix, and it depends on your healthcare system. In totality, the evidence is neutral, but we need a more refined look at the data, I think. Is that fair?
Thank you. I think we totally agree with that. And because of the time, we have to close this session. And I thank you for your time. And I also thank for all the participants for this session. And we have a very great discussion to clear this question. Thank you very much, all of you. Thank you.
Thank you for joining the Best TAVR case session. And this is the Best TAVR case part 1 and the Edward session. And the moderator is Dr. Ying and me and D.W. Park. And we are inviting expert panel and Dr. Jimmy Hon and Dr. Tsun-Jui Liu and Dr. Nan-Chun. We're going to start the first case and Dr. Chuang and the case number 1. Okay.
So good afternoon, ladies and gentlemen. I'm Yu-Chuan from Taichung General Veterans Hospital in Taiwan. So today is my great honor to present a case in Taipei Valve 2025. Today my topic is when rare becomes real, acute leaflet dysfunction after immediate TAVI procedure. So I have nothing to disclose. This is our case today. The patient was a 77-year-old female with a history of heart failure for several months, and it turned out to be a severe aortic stenosis. And the patient also have multiple comorbidities, including end-stage renal disease, and was under regular hemodialysis for several years, and also type 2 diabetes, hypertension, as well as hyperlipidemia. The patient also had the triple vessel disease, which was treated with multiple long stenting at local medical hospital. So initial surface ECG shows sinus rhythm without obvious heart block. However, the chest X-ray showed obvious pulmonary congestion. Here is the TEE before the procedure. So as you could appreciate on both upper side, there was a severe calcification with limited valve motion. Not to mention, there is also at least a moderate aortic regurgitation. Fortunately, the wall motion at this moment was relatively preserved with the LV ejection fraction of around 51%. However, due to multiple comorbidities and also advanced age, with a STS score around 15%, the heart team decided to send the patient to a TAVI procedure. So here is a heart CT scan before the procedure. As we could appreciate on at least a CT scan, the area was around 355 for the annulus area. However, the challenge is a small SOV as well as a small STJ in this patient. So I have to say the first challenge in this patient is the coronary risk, especially over left coronary artery. As you could appreciate on this both evaluation, the left coronary height was quite low, it's around 8 to 9 millimeter. And we decided to use, if we decided to use a 23 millimeter Sapien 3, the VTC is less than 4 and the VTA is less than 1 millimeter. So I have to say it's a high coronary obstruction risk patient. So after discussion from the heart team, we decided to go transfemoral TAVI procedure. Sorry, I did not show the artery, but the bilateral femoral artery was okay for a TAVI procedure. And we decided to go with Sapien 3, 23 millimeter heart valve and with underfilled 1 millimeter. The oversizing percentage for the patient will be around 7%. And because of the high coronary risk, we decided to go with a concomitant chimney stenting. So here is the first step. We engage the left coronary from left femoral artery with the EBU guiding. Then we send the drug-eluting stent down to the distal LD for the upcoming chimney stenting. So the next step is to cross the aortic valve. As you could appreciate on this angiogram, it looks to be quite smooth. And after we cross the valve, we change to a Confida stiff wire. So we just forget what's the reason we use Confida, but we usually use a Safari in the case of a Sapien heart valve. So when the Confida wire was set, then we align the valve and the balloon in the descending aorta. So everything seems to be very smooth at first. So the next step is to cross the valve with the Sapien 3 heart valve. When we cross the valves, it seems to be no struggle, and we could cross the stenotic valve very smoothly, even without the predilatation. Initially, we decided to go with a nearly left coronary cusp isolate angle because we try to know the exact relationship between the left coronary artery and also from the heart valve. So this is the angle we choose to deploy both the valve and the drug-eluting stent. So the next step is under rapid pacing at 180 beats per minute. We deploy the coronary stent first and followed by the TAVI valve. So initially, everything seems to be okay. And here is, after the valve was deployed, we retrieve the whole catheter smoothly without any struggle. However, just when we thought everything seemed to be fine, and this was also evidenced by the aortogram as well as the real-time TEE, the leaflet seems to be working quite well initially. Let's see it again. On the aortogram, the leaflet seems to be quite well, and there was no obvious paravalvular leak or even aortic regurgitation. And also on the TE, the leaflet was functioning quite normal. However, the patient suffered from persistent low blood pressure even after the procedure. So after excluding some very dangerous situations such as cardiac tamponade, aortic root rupture, dissection, etc., we checked the coronary artery directly. Fortunately, both left and right coronary was patent, and there was no immediate obstruction. However, just 10 minutes later after the valve deployment, the patient suffered from sudden hemodynamic collapse. So here is the situation during CPCR. Fortunately, after 2-minute resuscitation and followed by the emergent insertion of the IABP, the patient restored heartbeat. So we tried to find out what happened, and we checked the TEE immediately after the patient restored the hemodynamic status. As we could find on both long axis and short axis view, there seems to be a large and acute intravalvular aortic regurgitation. So we are not quite sure what happened during the procedure, but at this moment we found there is a new onset and acute intravalvular aortic regurgitation on both long axis and also short axis view. So since we thought this might be the reason why the patient suffered from low blood pressure initially and suffered from the subsequent hemodynamic collapse, we decided immediately to implant a second Sapien 3 23mm heart valve, as the size was same as previous one, and we decided to go with underfilling 1 millimeter volume size. So this time we decided to go a little bit lower because initially we tried to recannulate the left coronary artery with a coronary wire, but in vain. So we decided to go a little bit lower and just try to avoid the coronary obstruction. So after the second valve was deployed, everything seems to be stabilized, including the hemodynamic status. And here is an aortogram after the second heart valve was deployed. The heart valve function seems to be very okay, and the most important thing is the blood pressure restored, and everything seems to be very stable. So fortunately, the patient could be removed both the IABP as well as the endotracheal tube on the next day, and the patient was discharged 6 days later after hospitalization. So during the 3-year follow-up, I would say the patient was still doing well, but the patient have also received PCI twice through the chimney stenting because of the long stenting from the local medical hospital. And so this is how we do PCI through the chimney stenting. So this is our discussion today. To be honest, acute leaflet dysfunction in sapien heart valve is very, very rare. And this is one case reported by Dr. Couture. And because of, in their case, few years ago, because of one leaflet was stuck and was dysfunctioned, so they also experienced immediate aortic regurgitation during the first heart valve was deployed. So how do? They also treated the patient with immediate valve-in-valve procedure. And here is another case similar to the one we met. They also suffer from immediate aortic regurgitation, and it was an intravalvular aortic regurgitation after sapien 3 was deployed. And in their case, they thought it was because of the interaction from the native leaflet and the new heart valve. So I try to list some of the cause of acute leaflet dysfunction, although it's pretty rare. So probably we can categorize it into three categories. First, we have to exclude those functional mimics. For example, because of the rapid pacing, the patient might suffer from myocardial stunning, and sometimes this might mimic leaflet dysfunction. On the other hand, we have to exclude whether there is a wire or catheter gelling during the procedure. Next, we can move to the intrinsic valve intrinsic cause, such as a leaflet entrapment, or very rare, maybe there might be some situation that it was due to the structure defect from the valve itself. But I have to say it was pretty rare, and I have not seen any case report in this situation. And last but not least, we have to check those procedure images to check whether there is a procedure-induced cause, such as maybe there is some malposition or under expansion. And not to mention, we have to make sure there is no balloon-related or system-related injury or catheter-related interference. And last but not least, in our case, because there is chest compression, so maybe it might also cause the heart valve distortion. So back to our patient, the most strange part is that because the heart valve seems to be functional normally at first, but after we try to cannulate the coronary artery, it turned out to be a tragedy that maybe there are some interaction between the catheter or the wire or even the pigtail itself with the aortic new leaflet. And during the chest compression, maybe there is another cause that there is a possibility we cause some valve distortion. So, ladies and gentlemen, here's my conclusion today. Acute leaflet dysfunction is extremely rare in now a very reliable sapien heart valve, but we might encounter this situation in very rare situation. When we encounter this kind of situation, most of the time we can manage it with emergent valve implantation. And although now in the electrosurgery era, to deal with this kind of a high coronary risk patient, we could still use the chimney stenting to protect the coronary access. So in our patient, although we experienced the acute leaflet dysfunction, but we could still manage the situation with immediate valve-in-valve implantation, and the patient was still stable during the 3 years follow-up. Thank you.
Thank you. It's a very interesting case. Any comment or question to this case? So I have one question. You know, that you do under transesophageal echo, and after chimney stenting and the implantation is a valve, and the valve leaflet function is good.
Yes.
But after CPR, there is some intravalvular severe acute AR. So what is how do you think, what is the first cause of cardiac arrest?
Yes, I think this is the most important question in this patient. So because initially the heart valve was functioning normal, so we also try to exclude other situations such as a cardiac tamponade or annulus rupture or even aortic root dissection, etc. But we found no any clue. So the only thing we thought it might be probably some kind of a cardiac stunning, but actually, the patient restored the heartbeat immediately after the rapid pacing. So till now, we try to review once and once again. We still could not clearly know the initial reason. So I have to say, in this case, maybe acute leaflet dysfunction might be the secondary to no matter the catheter manipulation or during the CPCR, it might not be the first cause of the first cardiac arrest.
So, and a couple of weeks ago, we experienced a nearly identical case, and My suspicion is about although you did the chimney stenting, there could be, you should rule out any sinus sequestration. Also, in our case a couple of weeks ago, and we called the shoe side LV. Okay. That means is after relief of aortic stenosis, and then if a patient heart rate is very fast, that is called shoe siding LV. Yes. Is rate is very fast and the blood pressure not maintained. At that case, we did CPR. A CPR caused some, central configuration was broken even after CPR. That was nearly identical case. And at the time, we decided to first blood pressure drop is a shoe siding LV. Yes. That was a main effort, even after TAVR procedure. And the second cause of central AR, we suspected the chest compression was the main cause. And we until recently, we performed more than 3,000 cases, mostly Subclavian valve. We experienced one case immediate after TAVR is a frozen leaflet, just one case. After immediate TAVR, and the one leaflet does not move. It's a very severe AR. That was confirmed the echocardiography. But your case is not the frozen leaflet. Initial the function is very good.
Yes. So thank you for your great comment.
We have our second case by Dr. Narathip. Welcome, Dr. Narathip. It's entitled TAVR with coronary access.
Good afternoon, ladies and gentlemen. My honor to be here. I have a quick case to share with everyone. This is a 73-year-old patient who had severe aortic stenosis. He had history of coronary artery disease, and he underwent triple bypass with Lehman graft to LAD, saphenous vein graft to diagonal branch, and left radial artery graft to PDA 17 years ago. He was admitted at outside hospital, and he was transferred to our hospital, and the echo confirmed that he had severe aortic stenosis with Vmax 4.6 meter per second and the mean gradient of 55 millimeter mercury. So diagnosis was confirmed, classical severe AS. Because of, so we did CA, and we also did coronary angiogram. It showed that all grafts were patent, but the patient developed a new stenosis in circumflex. However, he didn't report any anginal pain before, so we decided to proceed with TAVI. Let me show you the CTA analysis. So the patient has annulus of 21 times 26.5. Annulus area is 446, and area derived diameter is 23.8. LVOT was clean, and the sinus were okay. So I think it is like 32, 32.5, 35. So the sinus of Valsalva is quite big, and STJ is not a problem. The STJ is 29 times 30 millimeter mercury. So basically, I think the problem in this case is heavy calcification. We got calcium agastan score of 5,000. It is quite symmetric in all three leaflets. It is about like 2,000 at left coronary cusp, 1,500 in right coronary cusp. The left coronary height is 11, and the right coronary height is quite okay. I think the left cusp is quite borderline. So the rough choice in our hospital would be Sapien, because we have no concern for the rupture, because it is tri-leaflet. Although we have the patient has heavy calcification, I think with careful measurement, Sapien 3 would be okay. And in Thailand, we have both S3 and S3 Ultra. In the patient with heavy calcification, I think we would prefer Sapien 3 Ultra, because the outer skirt is is higher, and I think it seals pretty well with heavy calcification. And we don't have to be very aggressive with sizings. So in this case, I would pick S3 Ultra number 26, and I decided to -2 mil, and it will result in 6% over sizings. So during the procedure, our approach is minimalist. So we use conscious sedation, transthoracic echo guidance, and wire pacing, since conduction was normal in this patient. Right femoral artery approach, and we use 7-3 Ultra number 26, and the second picture is during the deployment. Our patients attending is very tough with us, so he gave me like 1+ paraleak. So I decided to do another inflation, and I +1 ml in to correct this. And the right picture is the final shot. There was no leak at all and no gradient. And this time I thought, the flow in the coronary artery was quite normal. And don't forget that this patient has limb graft to LAD and saphenous vein graft to diagonal branch. So he left the cath lab with this very good result for TAVI standpoint. But, during overnight stay, the patient complained of one episode of chest pain. EKG was done, and it was normal. High sensitivity troponin were sent, and they were elevated but not rising. And the pain resolved after our health staff gave sublingual nitroglycerin to the patient. So the patient was sent back home next day, and at a follow-up visit, I had a discussion to the patient. He never had anginal pain before, but he developed like a lesion in left circumflex, but one questionable chest pain, after TAVI. So we decided to bring the patient back for CAG and PCI of circumflex. So I got in with radial artery approach, 6 French DL35 guide catheter, and the first picture is LAO caudal. I think we started to see a questionable ostial left main lesion. But, in another projection, in spider wheel, it looks okay. But anyway, I couldn't selectively engage left main, so I floated Chuang blue wire in circumflex, and the right picture show isolated left cusp view. And I think in this angulation, I think it is the best to demonstrate, severe stenosis. I'm not going to say left main. It is more like, the distance between the valve and STJ that cause severe stenosis. And we did IVAS, and so this is the IVAS pullback from left main. You started to see a big calcium chunk, from like 4 to 9 o'clock, and you see a slit-like orifice, at STJ level between the valve and STJ. So in this case, we did predilatation with 3012 semi-compliant balloon and used Sky Plus 2 ST guide extension to park in left main. Deploy 4018 science drug-eluting stent. And the first picture is the picture after the first science was deployed. We still see a recoil. I think, at the area, there still has some residual stenosis from the recoil. Since the patient had heavy calcification, I decided to place another layer of science stents, to improve the radial strength, and did PCI of circumflex. And the right picture is the final shot. So I think, we got a pretty good result. So this is my take-home message. I think in this patient, I thought, coronary artery would be okay. I didn't even protect it because I thought, the height was enough and the sinus was quite wide. But since, the degree of calcification was very bad, I think, I shouldn't have protected, left main in this case. I was lucky enough, to get away with this. But I think with this heavy calcification, heavily calcified valve, I think a balloon expandable is a good choice because the radial strength is very good. And also, I think sometimes when we do chimney stents, one layer is not enough. Sometimes you see acute recoil. So I think the second layer of drug-eluting stent is needed. Thank you very much.
Thank you very much. That was very, very interesting, actually. I don't know if you use circle method for every kind of valve analysis.
Yes, we do. Yeah. And in this case, we did valve. We use circle method, and we placed like 25 millimeter circle, and I thought it was okay, but we saw it that with this heavily calcified leaflet.
Yeah. Yes, I think this case is a typical case of a sinus sequestration. If you're gonna do adjacent coronary angiography and it looks okay, but if calcium chunk block the coronary ostium directly, there was shock. His blood pressure is going abruptly. But it's like a sinus exit was blocked by calcium chunk. Yeah. Immediately patient looks okay, but it's after leaving cath lab and moving to the CCU or general care, patient continues complain the chest pain and the blood pressure is borderline. That was typical case of a sinus exit, sequestration by calcium chunk. We have experienced some of the case. At night time, you should go cath lab. But it's like looking at the last picture, looking at the C, there is still like a flow. There is calcium chunk is nearly blocked the sinus exit. That was typical case of sinus sequestration.
Yes.
I also try to assess after putting the circle whether the rest of the sinus has got enough space to accommodate the thick leaflet. So I take that leaflet calcium into the chunk, into the calculation as well. So I don't know whether that's something.
I think Kim has said if you have a suspicion, you do directly IBUS.
Yes. Yes. Yeah, I think I was fooled by, I think, it was not true isolated left cusp, from the begin with. That's why, I saw something, but I miss it, to be honest, from doing the TAVI procedure.
But you cannulate it very easily, right? After the case.
Not easy.
Okay.
Yeah, you should do the pullback.
Yeah.
At the final shot.
Yes. Okay.
Thank you very much.
Thank you.
The next speaker will be Dr. Kent Anthony L10, who is coming from Philippines. He's talking. His topic will be TAVR in heavily calcified aortic root. Dr. Anthony, please.
Good afternoon. It is my honor to be presenting this case before you. I'm an interventional cardiologist from the Philippines, and our TAVI team is relatively young. We have just recently started using the SAPIEN platform last month. And as much as we would have wanted simple cases first, but sometimes cases just come in with, and we are forced to deal with things. So we are presented with a female patient for a relatively young female patient for optimization, undergoing chemotherapy with doxorubicin, being treated for breast cancer. And the ejection fraction was depressed, and so we were asked to evaluate the case. She has CAD in the past and questionable hypertension. So she's complaining of decreased functional capacity and shortness of breath. So on baseline TTE, we were surprised to see that she has a bicuspid aortic valve with mild AR. This is her initial picture. So she has an ejection fraction of 48%, and the aortic valve area is 0.41 with a high velocity of 5 and a mean gradient of 67. Coronary angiography was performed, which showed non-obstructive coronary lesions. So on CT analysis, this confirmed the bicuspid aortic anatomy with the type 0 variant. And also, the patient had a relatively small annulus with an area of 336. The configuration is roughly tubular. So the sinus of Valsalva area and the annulus area were roughly the same measurement. So the coronary heights were borderline, even bordering normal. So it's 12.6 for the right coronary and 14.2 for the left. However, we were worried about the chunk of calcium in the right cusp, in the right leaflet, which we feel that may obstruct the right coronary ostium as we expand the valve. So this is further analysis of the anatomy. The access pathway was unremarkable. So here we really see that I failed to get the calcium score, but it is safe to assume that the valve is really heavily burdened with calcium. So we did a circle method because it was we were thinking of whether to use a 20 or a 23, and it's from our circle method analysis, it seems to be that the size 20 would be a better choice. Look at the last analysis wherein we show the VTC. The VTC for both, supposed to be the VTC should be ideally measured with the level of the leaflet still being seen on CT, but the takeoff of the coronaries were also unusual, that which is expected for bicuspid anatomies. So the VTC of the left coronary artery and the leaflet was 2.5, and then for the right is 2.1. So we already initially planned of protecting just the right coronary artery with respect to the calcium chunk also on the right side. So our heart team conclusion would be to, initially we really wanted the patient to go for surgery, but the patient was not in the proper emotional and mind state. She was very depressed of having breast cancer and having to undergo open heart surgery. So she was really adamant of just not having surgery. And we were also concerned that we may delay the course of her chemotherapy if we send her for surgery. So we opted to do the transfemoral TAVI for her. We wanted to use a pre-dilatation with an 18 millimeter balloon and a Sapien size 20 with an RCA protection in the right side and RV pacing. So this is our initial pre-dilatation of the balloon. Immediately we see that the right coronary ostium was occluded. But we already anticipated this, and we put in already a stent inside, ready for a possible chimney procedure. Incidentally, we also see on the left side, on the left coronary, there's also some impinging of the left ostium, which was not seen in the original coronary angiography. So we decided to do a left. We decided to do a left coronary protection. So we slide in a stent in the left coronary also, a 4-0 stent in preparation for possible chimney stenting of both sides. So this is our deployment. And then it took us a while to deploy, but upon deployment, the patient went into arrest. We had to do CPR, but fortunately, with the valve already open, we were able to revive her in less than 10 minutes. So we decided to deploy both stents in the left coronary and the right coronary. So visibly, the stent wasn't, the balloon expandable Sapien was not really fully expanded. we were worried about the calcium chunk if we further become more aggressive. And incidentally, at this point, our imager also mentioned that she was already noting pericardial effusion, which could probably be from the CPR or probably from our initial expansion. So our initial gradient, so this is our final injection once we revived her. Our gradient initially was 120, but we were able to reduce it at 11. So we stopped at this point and sent her for close monitoring. Luckily, the further echo surveillance, the effusion did not progress, and the patient successively improved and was discharged in day 4. So we plan, our future plan would be to start with, given that the stent was not fully expanded, the valve was not fully expanded, we wanted to start her on a NOAC together with a dual antiplatelet. So this was her echo on discharge. The gradient was 13, and then it was signed out as an EOA of 1.5 and then a mean gradient of 13, and with a normally with no significant paravalvular leak, with mild transvalvular regurgitation. So my key takeaways for this case would be surgery should always be still the first line for heavily calcified valve anatomy if feasible. Heavy calcification in the aortic root requires meticulous planning and anticipation. The balloon expandable valve offer the advantage of, in terms of radial strength, more circular valve configuration, and implant depth precision, but at the expense of higher risk of serious aortic root injury and a higher post-procedural gradient. Balloon predilatation was very helpful for us in both the sizing and the anticipation of the calcium interaction with the coronaries. And then chimney stenting, although a good bailout strategy, may limit future coronary access and valve-in-valve option. So for her, we still spoke to her that she may still require surgery in the future once her chemotherapy and her cancer has been taken care of. And then lastly, team familiarity is of paramount importance. Thank you very much for your attention.
Thank you, Dr. Ken and Tony, for your very excellent talk about this very tough case. Is there a question from the panelists? Well, my question is, since the ascending aortogram during ballooning of the aortic valve already showed severe compromise of Lemon coronary. Why didn't you just use simultaneous Lemon chimney stenting instead of a staged procedure?
After that, we already put in a stent, but we were hoping that we can get away with not putting in the chimney. Yeah, but in retrospect, yes, we should have already deployed the left stent as well. Yeah.
My short question is, if you have if you meet the similar case, what is your choice next?
This one.
Yeah.
So initially, the primary question of which valve to use, definitely, if I'm going for the TAVR route, it will still be balloon expandable for the radial force, and especially if the coronaries are questionable, the short frame would be very beneficial. But if the patient is open for surgery, I will send this patient for surgery.
We experienced a similar case, and I think a very severe calcium chunk. And you can do minimal thoracotomy. Now it's cardiac surgeon doing well.
Yeah.
And the minimal thoracotomy and the wide excision of a calcium chunk, and then put the rapid deployment of a valve, sutureless valve would be some option for such case.
Thank you very much.
Okay. Then let's move to the next question.
Let's welcome the next speaker. Dr. Denong Kaikes, his report, excellent case of alternative access is from the subclavian artery. So let's welcome Dr. Denton.
Okay. Good afternoon, everyone. My name is Dadon Kalkes. I come from Queen's Sigit Heart Center, Khon Kaen University, Thailand. And it's my great pleasure to be here to share my case with you. This is my disclosure. My case is a 79-year-old female who has the medical history of diabetes, hypertension, and chronic kidney disease, and presented with heart failure for 1 month. And from the echocardiogram showed the severe aortic stenosis with the LV ejection fraction of 84%. The angiography showed normal coronary artery, and we are consulted to do the TAVR. The patient has quite high surgical risk. The SDS score allows 7.5, and she has the creatinine allow 1.6, and has the anemia hematocrit of 24. So this is her EKG, show the normal conduction sinus rhythm with LV hypertrophy, and also the chest X-ray show cardiomegaly with mild congestion. And if you can see something. This is the echo, also have left ventricular hypertrophy with the calcified aortic valve, and the dry leaflet aortic valve with the mean pressure gradient around 40, so compatible with severe aortic stenosis. And this is her pre-TAVR CT, also show the diameter, the mean diameter around 21, the minimum around 20, and the area, annulus area of 369, and perimeter of 68 millimeters. The LVOT is quite the same size and small, a little bit smaller than the annulus. The FTJ is quite big enough. It's around 29 millimeters. Sorry, the SOV, and the STJ is around 26, 27 millimeters. The coronary height also, I think, also adequate. The left side is 10.9 millimeter, and the right side is 13.7. The angle is a little bit around 67 degrees, and the calcium is much more on the non-coronary cusp. So from the annulus and the surrounding structure looks favorable for TAVR. However, when we look at the anatomy of the axis, you can appreciate the folding of the descending thoracic aorta with heavy calcification at the aorta as well. And for the iliofemoral axis, it's quite okay. So the iliofemoral sizing, and there's less calcium in the iliofemoral artery. So because of the folding and calcification of the thoracic aorta, so we try to see the other aortic axis. Look at the direct aortic approach. That do we have any problem if we need to do direct aortic? It looks like the working range, it should be okay, and the angulation, it should be okay. And the subclavian approach for the right subclavian is the diameter is around 6 to 7 millimeters, but have some calcification. And the left subclavian has quite small in caliber, around 4.7 millimeters. Actually, the carotid is very big. It's around is adequate, and also less calcium for the carotid in both sides. So, what will your plan of management in this case? Will you advise for surgery, or you will do the TAVR anyway? And the access, will you try the transfemoral approach to handle for the folding of the descending thoracic aorta, or will you use the aortic access? And which one is your preferred, and how is the valve type and size that you choose? So I do the coronary angiogram first and try to manipulate the descending thoracic aorta with the longitudinal Y and the long sheet 65 centimeters, but the descending aorta cannot be stretched, and because of high calcification. The coronary angiogram shows no segment coronary artery disease. So from the study of my friend and mine, also we try to find the predicted list of iliofemoral vascular complication, and we come out with the cedar-sinai index score that for by the summation of the curve angle multiplied to the number of curves and divide by the luminal diameter. And if the score is more than 100, it has high sensitivity and specificity for the iliofemoral complication, but maybe not in this case, because this one is upper into the descending thoracic aorta. So in my perspective, when I manage patient with severe aortic stenosis, I will consider for the clinical anatomy from the echo and CT that is favorable for TAVR or not by the clinical of age, the echo, the CT, and the lifetime management for the 10 years that we have any other option. And if all of them is favorable for TAVR, we do the transfemoral TAVR. But if not, we will calculate for the surgical risk. If the risk score SS is low to moderate, we will do the surgical AVR. But if it's high surgical risk, we may need to reconsider the TAVR and overcome the complication that maybe have some risk. If it's high risk for vascular complication, we generally maybe we try the aortic access. If the risk of the coronary obstruction, we try to do the leaflet modification, shortcut or chimney stenting. And if it's high risk for annular rupture, we may use the self-expandable valve. So in this case, we discussed in the heart team, and we think the patient had not a good anatomy from transfemoral TAVR because of tortuosity and calcification of descending aorta, and the patient is quite high surgical risk, so we plan to do TAVR with alternate access. This one we choose right subclavian artery because mainly because I am more familiar with the subclavian approach, and I don't have an experience for the transclavian approach, so we choose the subclavian, and we choose the balloon expandable valve. So we use the surgical cut down to the right side of the chest, and by the cardiothoracic surgeon, and we dilate puncture to the subclavian, and we cross the valve with the JR catheter and use the Londoquist wire to make more support, and then insert the guide and the sheet and insert the valve into the aortic valve, and we deploy using the Sapien 323 millimeters. And but the procedure went quite well. We have some difficulty in terms of insertion, but it's nothing, and the valve function is good, and we check for the subclavian artery after doing the procedure. It's good and no dissection. The gradient is down to just allow 9 peak-to-peak gradient of 9 millimeter mercury after TAVR. And the echo also show good valve function and no paravalvular leak with the mean gradient of 15 millimeter mercury before discharge. So my learning point from this case, I think the alternate access for TAVR should be considered in severe aortic stenosis who has unsuitable for transfemoral approach and with high surgical risk. And pre-TAVR CT is very critical to select the alternative access. And subclavian approach may be one of the treatment options. And I think another thing that we have to consider is the experience or our familiar with the subclavian for the aortic access. For this one, we choose subclavian because of the team and I are used to and familiar with the subclavian approach more, and we didn't use the carotid before, so we choose the subclavian in this case. Thank you for your attention.
The audience, do you have any questions? My question is because I'm a cardiac surgeon, so I want to ask. How do you decide to choose the right subclavian, not carotid artery? This is my first question. And the second question is, do you choose the self-expandable valve? Because we know the subclavian access is officially out of IFU for the Sapien 3 valve. So do you choose a Medtronic valve for this case?
The first thing, we didn't choose the carotid because we don't have the experience of the carotid approach. So we choose the thing that we have the experience. And the second thing, because we choose the right side from subclavian because the left side has more caliber. So from the right side, it's very difficult to handle the self-expandable valve because of the angle. And we think that the balloon expandable valve, we have the flex, so it can help us to align the valve more better than we use the self-expandable valve.
So have you done post-dilatation? Because it seems that the post-TAVR gradient is still high.
I think we didn't do.
Was it the direct puncture or was it cut down? I thought I didn't get
cut down.
Cut down, right? I see.
But we didn't do the conduit. We just puncture to the subclavian.
So we tried that before a few times. We started off with cut down, and we are doing direct puncture now. But important thing about direct puncture, you must have a brachial bailout. Brachial sheath, a small sheath, just in case you need to have a covered stent.
Okay.
But well done. That's very interesting. Well done.
Thank you.
Okay, let's move to the next case by Dr. Hong from Korea.
Okay, thank you for nice introduction. I think I am the only imager in this room, so I don't know why I should, present a TAVR case. It's really difficult. The reason why it's difficult is I thought this is best TAVR case. It's a best TAVR case, but everybody presents some complicated case or overcome some problem. It's really difficult for me because DW Park, though our center, is a big fan of the self-expandable valve. Our Professor Myung-Ki Hong and Young-Gu Ko is prefer self-expandable valve more than 1,000 cases. 80% I'm very okay. They are not here. Only 10 or 20% cases balloon expandable case. It's very simple and straightforward. It's a very nice case. So every tough case is done by self-expandable valve. I'd like introduce just only one case I did against our interventionist. I fought with them, and I put balloon expandable valve. Please check it. What is the best option, best solution for this case as an imager? It's really difficult to fight in the interventionist, right? So you are the interventionist. So this is the 82-year-old female. This is my patient. And she had a dyspnea and chest pain and the ESRD and hypertension, diabetes. And she has one vessel disease, the LAD. And she is very small, and 157 centimeter. And she already taken clopidogrel and diuretics. And Euroscore risk score is about 3.4, and the SDS score is about 14. So this is X-ray and the ECG, left bundle branch block, okay? And this is echo, severe AS and severe calcified, and regional wall motion abnormalities, LAD territories, and the moderate AR. Ejection fraction is about 48%. Valve area is about 0.88 square centimeter. So here, the LVH and maximum velocity is about 48. Mean pressure gradient is about 48. This is a TAVR CT. It's heavy calcified. But problem is here, we already discussed a lot in the morning session. Her annular size is average about 21, and area is about 360, and perimeter is about 68. And the sinus of Valsalva is quite small. The problem is the left coronary height is 9.5 millimeter. Patient had LAD problem. So 82-year-old female, ESRD, and LBBB, and low coronary height, small annulus. Professor Park, what do you want?
This is absolutely not So I think we can choose the Sufficient and Evolute valve if this patient is my patient. I would like a Sufficient first, and because and if you select Evolute, coronary access is nearly impossible. Yeah.
Yes, but our interventionist, the three interventionists in heart team discussion, all the interventionists have a strong opinion to evolute valve because in the low coronary height and small annulus, they prefer as usual. But I think this patient is 82 years old and the ESRD, and problem is she had a left bundle branch block and ejection fraction is very low. I think in this patient, other risk factors can be overcome. But left bundle branch block and pacemaker insertion risk is really, great deal for this patient. So here, I insisted they're very serious because every time I follow to interventionist. But in this case, I strongly, insist my opinion in this patient. Let's try balloon expandable valve. They ask me why. This patient is have a lot of risk factors in the small annulus. So I showed data. So they continuously persuade me in the self-expandable valve is a larger EOA and lower gradient as presented today. And but I insisted. So this morning, the American surgeon, he told me Doppler velocity DVI is very important, but DVI is also Doppler. And all the gradient is self-expandable is better. But you should know echo and CAT AV gradient is quite, have inherent limitations. Doppler, every time Doppler overestimate the gradient across the native or mechanical valve due to these kind of errors. And the problem is here, echo and CAT in the real world data, in the concordance rate in the native valve is quite good. But after valve implantation, in the TAVR valve or tissue valve, is quite discordant. It's very important. So I don't believe the valve gradient, if gradient is higher in the immediate post-valve implantation, is worse outcome. I don't believe it. The small difference in the gradient do not increase mortality or outcome. So in heart team discussion, severe but moderate PPM may be associated with increased mortality, interventionist. And the echocardiographic gradient may overestimate the TAVR, valve dysfunction, and the PPM is from imager. And I think pacemaker insertion is more dangerous in this patient than patient prosthetic mismatch. And I know you can protect in the LAD problem, low coronary height, by the protection. But they want some, in the self-expandable is the quite straightforward, very easier process. And in our hospital, it's much easier than the balloon expandable valve. But I continuously persuade, this is my patient, please do it. The intervention asked me, if there's something wrong, you are in charge. So I said, it's okay, please do it. So we decided to TAVR with balloon expandable valve with ICE guidance. In our hospital, most of cases, more than 90% of cases in the light sedation with the ICE guidance. So most of the ICE guidance is a lower intermediate risk. Conventional TAVR is performed by ICE guidance. So this is the result. So it took more than 2 hours because of protection. Usually it finished in the less than 1 hour. So we insert in the guidezilla and protect it and put a balloon with the ice guidance. It's quite easy. It's not very difficult. And we implanted the sapien valve under ice guidance. It's very easy. And then, and the TAVR with the sapien, after implantation, we checked ice, and there's no probable leak. It's a very small leak. It's acceptable. And this is a post-TAVR TT. It's quite good result without any problem. So after this TAVI, I told our interventionist, see, you can overcome it. So please please consider my opinion. Don't do that. It's your opinion, their opinion. So this is our lesson from this case. In terms of small annulus, it's a great deal. But all-cause mortality and the cardiovascular mortality, there's no difference between self-expandable and balloon-expandable valve. And beyond the small annulus, we should consider multiple factors for successful result, including age and lifestyle and body surface area and the PPM risk. And also, furthermore, avoid the severe, PPM with a balloon expandable valve, and the low coronary height can be, overcome by protection. And also, ice guidance provide continuous monitoring with the minimal use of a contrast agent. Thank you for your attention.
Well, I totally agree with you, and I saw you are the sales representative of Edwards. And any comments?
Edwards, the confidence. I think in the future, there's the FX class with very large coronary access. So it's still a problem for the low coronary height, or does we still think about the setting? I know that the setting is not very easy because it's for
I think a 23 has a height of 18, and the valve is just at the lower half. So it doesn't matter.
Yes.
No problem.
So it's my comment, and it's Professor Hong is an echo specialist, but it's one of the major problem our interventional cardiologists, we have some misconception about the echo measure the EOA, and we don't know understanding well Bernoulli equation, and we are is confidence of the report of echocardiography. We are much concerned about the PPM rather than echocardiography specialist. Although you are speak about the PPM, it doesn't matter, and still interventional cardiologists have some misunderstanding of PPM as directly impact long-term durability and patient outcome, and still concerned. Yeah, I think that is truly, I fully 100% agree with Professor comment.
You have told us only 7% of patients need to concern that in Asian population.
If this patient is 70-year-old, very active person, and have coronary problem, I really, hesitate put, Edward valve, because, in the PPM, maybe have a great deal for younger age, but this is 82 years old. Why?
Yeah, I totally agree. For this patient in our hospital, with box standard, no-brainer, Edward sapien, valve implantation, balloon expandable. This is an old patient. This is a small patient, and your coronary height is low. So with a 23 sapien valve is 18 millimeter height. If you put 80-20, you got 4 millimeter below, probably about 16 millimeter above. Your coronary access is completely protected. If you put a self-expanding valve, you will have a supraannular position. You've got your skirt at the bottom, and if the 5% that you do not get commissural alignment, then you're screwed with a low coronary height. That you've got 5% chance of not getting coronary alignment. So SMART trial results to me is only for suitable patient, not for all patient. This patient, you cannot apply SMART trial data.
Yes.
Also, if the coronary height is just 9, if you use self-expanding and the valve was 14 or 13, that high, so you have to put it deeper. That would be another issue.
And every case we are attending the case with eyes guidance. So we are, we discuss a lot, and we can overcome. If something happened, we can handle it immediately. So that is the good options for the eyes guidance.
Okay, thank you very much, Professor Hong. And we learned a lot of interesting case from you. And we introduced the case number 6 and the TAVR with low coronary height, Dr. Huan-Chiu Lin.
Thank you for a kind introduction. Good afternoon, distinguished moderator and all audience. I'm Huan-Chiu Lin from Zhenxing General Hospital, Taiwan. Today, my best TAVI case will be a patient at high risk of coronary obstruction in native TAVR. So I have nothing to disclose. So coronary obstruction, which is one of our most feared complication after native TAVR procedure in the cath lab. So in a recent study from the Spanish registry who has involved more than 13,000 patients, the incidence of the coronary obstruction in native TAVR is only 0.8%. However, it is catastrophe if it occurs because of the mortality in hospital, and 1-year mortality will be around 40%, which is extremely high. And the incidence of the coronary obstruction remains steady over the past decade. For multiple studies to analyze the CT to try to identify the predictor of the coronary obstruction, they have offered that maybe the coronary height less than 12 millimeter, the valve to coronary distal less than 4 millimeter, or even the leaflet calcification, which more than 600 millimeter would be a predictor of the coronary obstruction. So according to this Spanish TAVI registry, he had offered 5 CT risk factors, including a coronary height, sinus of cerebral diameter, the Bucky calcification, valve to coronary distance, and also the leaflet length is extremely higher than the coronary height, which will cause a significant risk of coronary obstruction. So here we came across with our case, which is an 83-year-old lady which has been diagnosed with critical aortic stenosis and functional class 2 heart failure symptoms, and also several syncope episodes have occurred during the past 4 months. Because of multiple comorbidity, her SDS score is quite high, which is 13.6 patient. This is a high-risk patient, and also a mild kidney dysfunction. So the echocardiography shows this is a severe calcified aortic valve, and the mean pressure gradient of the transaortic valve is 87 millimeter mercury. The multi-site CT analysis shows the area of the annulus is 379 millimeter square, and the diameter average is 22. And the sinus fossa is quite small, which is around 25 to 27, and there's also calcification over the sinotubular junction. The left main coronary height is around 11, and the right coronary height is around 13. The membrane septum length is 4.3, and this patient has a severe calcified aortic valve, which calcium is around 1,500. So we put the SAPIEN valve for simulation. However, we didn't choose the 23 millimeter SAPIEN, which is will be more compatible to her annulus area. We choose a 20 millimeter with 1 cc overfill, which will be 21.3 in diameter for simulation because of the low coronary height, and also the leaflet length was higher than the coronary height. So if we put the 20 millimeter sapien 3 for simulation, left vent coronary artery VTC will just around 3 millimeters. So if we try to identify this coronary obstruction risk, in this patient, she has 4, including the SOV, VTC, bucket calcification, and leaflet length. So this is a high risk of coronary obstruction patients. Therefore, after heart team discussion, our team decided to perform a basilica procedure for the left coronary cusp, and the valve we choose will be a 20 millimeter sapien 3 with 1 cc overflow, which is 3% undersize of the annulus. The estimated implantation depth will be around 3 millimeter, considered to the membranous septance, and it will be a moderate ppm for this patient if we use the 20 millimeter sapien 3. So now we start our procedure. We try to select the left coronary cusp with Air1 guide catheter, accompanied with a modified pigtail. Then after sinus flush, we can identify that we are in the right cusp, in the left coronary cusp. Therefore, we can leave that traversal the leaflet with the acetate wire with 50 watts electrocauterization. So after successful leaflet traversal, we use the real-time transesophageal echo to confirm the puncture site, which just traversal the leaflet here into the left ventricle. Then the snare was waiting at the LV outflow tract, and the looping was done for the AV loop. So we slowly pull back the snare. Then we can use the echo to confirm there's a significant aortic regurgitation after the looping. So before we perform the basilica procedure, we put the safari wire into the left ventricle because we are worried about the acute aortic regurgitation after the basilica procedure. So as you can see, now the patient diastolic pressure has down to 31 millimeter because we looped the aortic valve, which caused a significant aortic regurgitation. So then the electrocautery of the leaflet was performed with 60 watts pure carting, and then the leaflet was lacerated by the electrocauterization. Then we use the TE to further confirm. So as you can see, the leaflet was split by the electrosurgery, so which just in front of the left main coronary artery over here. So after the basilica procedure, there's a significant aortic regurgitation, which is quite eccentric, confirm our successful leaflet of the basilica procedure. Then the 20 millimeter sapien 3 valve was deployed under rapid pacing immediately because of the safari wire was in place, and with the valve was deployed with 1 cc overfill. So this is our final coronary angiogram. As you can see, there's some leaflet overhang at the left main ostium. However, because of the basilica procedure has successful done, which will split the leaflet into a V shape, so the coronary perfusion will be quite better if we just didn't do the basilica procedure or even do the chimney stenting for these patients. So this is our final aortogram. There's still mild aortic regurgitation because paravalvular leak after the procedure because of the heavy calcified leaflet. So this is our final TE result. As you can see, here's the mild paravalvular leak. And the mean gradient for this 20 millimeter sapien 3 valve was quite well, which is only 7 millimeter mercury for mean pressure gradient. And then valve to coronary distance, just as our predict, which is around 3 millimeter for left main coronary artery. So we all know that when the new pope was elected, the chimney of the Sistine Chapel will be blowing the white smoke. So for the native TAVR with the risk of coronary obstruction, do we have the white smoke? No. So before the choice between the chimney stenting and the basilica procedure, we both know that the chimney stenting will cause the difficult coronary access after the stenting, and also the stent may be thrombosis or deformation after if we want to do the post-dilatation of our valve, either the sapien or either the self-expanding valve. And also the patient have to take the dual antiplatelet therapy after the stenting. So this will increase the risk of bleeding after the procedure. There's a recent study that a retrospective study compare the chimney stenting and the basilica procedure, which involve 168 patients. So we just see the outcome for the 1 year outcome. There's no significant difference between the death, myocardial infarction, or even a stroke. However, as you can just predict that there's significant minor bleeding episode for the chimney stenting group. And also because of the prohibit of the aggressive post-dilatation, there's also more episode of the moderate to severe paravalvulic in the chimney stenting group. So, thank you.
Okay, thank you. Thank you very the interesting case. Any comment or question? So my question, I think this basilica technique will be done by the Dr. Ying and so Lee. Okay, so my question is about in our routine practice, many cases like some similar case, low coronary height is calcium chunk, and in your cath lab, do you routinely do the basilica technique? Also, any basilica technique associated serious complication do you experience in your practice?
Thank you for your question. In our experience, in the native TAVI case, our selection criteria will be quite strict. If we only do the high-risk patient for the basilica procedure. But I think in our center, we would like to perform the electrosurgery first. If we fail, the chimney stenting will be a bailout procedure for the patients. Yes.
For this patient, because the calcium is on the other side, so if we cannot push the calcium outward, it will just move to the left side. So that's why we choose to do it.
Also, although one of the technical concern about you think about the chimney valve, but TAVR, if you're going to use balloon expandable valve, we cannot exactly expect the moving direction of the calcium chunk. Although you make some wedge, cut the very calcium chunk, and during the implantation, that could be moved to another different way. There was still concern about the coronary obstruction. And do you experience some cases, although you did the basilica technique, but however you still experience coronary obstruction? Do you experience such a catastrophic case?
Thank you for your question. In my limited experience, we didn't encounter that patient. However, we have one case. We also performed a leaflet modification, and 3 months later, the patient suffered from delayed coronary obstruction. Yes, but it's not because we have repeat the CT analysis, and the CT show is not the leaflet that caused the delayed coronary obstruction. However, it's caused by the anatomy change by the self-expanding valve in that patient, which caused there's a dynamic compression of the between the sinotubular junction and the left vent ostium. Yes.
Maybe the other solution is to do balloon assist basilica. You dilate the valve, and the base will become a U shape instead of a V shape, and that can make a more destruction of the leaflet.
Okay, thank you, Dr. Lee.
You.
Okay, we have last but definitely not the least, we have Dr. Tsai, Chia-Ju, to talk to us about severe aortic regurgitation of the TAVR. Dr. Tsai, please.
Hey, everybody. I'm Dr. Chih-Ju from Zhengxin General Hospital. Today I will present a case about a severe aortic regurgitation after TAVI. So this is a 73-year-old man who had dyspnea and exertion for one month, and our cardiac echo found bicuspid LT valve with severe AS. AVL was about 0.5, and the Euro score was about 10. And the patient refused sternotomy surgery. And here is the T echo. So this is a type 1 bicuspid LT valve with RN fusion. And the mean pressure gradient was about 87 millimeter mercy. And here is the CT analysis. We can see the annulus diameter was about 26 millimeter, and the area was about 540 square millimeters, and the waist mass was about 26 millimeters. And this is horizontal aorta, and the ascending aorta aneurysm was about 6.7 centimeter. And we chose the Sapien 3 for TAVI. And we are difficult to cross the valve, so we use the transeptal puncture to cross the LT valve. And then we do the pre-dilatation with the 23 millimeter balloon for the pre-dilatation. As we can see, there is a fixed calcification nodule at here. And this is a RF Raphael location. Then we deploy the 26 Sapien and -2 cc, and we do the post dilatation with -1 twice. Then we check the cardio echo. We see the severe AR after the post dilatation. So here is the leaflet. And here is the location of the RN Raphael. So I think the leaflet was here, maybe related to the RF Raphael after the post dilatation. Then we deployed another Sapien 3 valve with -2 cc. Then there is no valvular AR and only mild parallel valvular leakage. So this is a bicuspid LT valve with a fusion Raphael and a horizontal aorta. So maybe the leaflet tears was related to the wire biopsy caused the uneven balloon dilatation, and the fusion Raphael caused the cut the leaflet. And the risk may be increased if we did multiple balloon dilatation, and replacing the valve with another same size can resolve the LT regurgitation.
Thank you very much. Very interesting. Do you think the dilatation caused the leaflet tear by compressing against the unexpanded or not fully expanded valve frame, or what's the mechanism of that leaflet? Can you anticipate? Can you guess what do you think has happened?
I'm not quite sure. I think maybe because it's a very horizontal aorta here. So the first is I'm not sure. Maybe a calcification. When we dilatation the balloon, the calcification cut when the leaflet was cut by the calcification, or maybe because I think the balloon was not even to dilatation. Maybe the valve was cramping, and when cut the leaflet during the dilatation. I'm not quite sure.
or even the calcium came through the valve stand and caused some damage. Has anyone seen a case like that before?
Is my question in the left panel after initially implantation Sapien 326, and is there the severe AR after initial implantation before post dilation?
No, there was no AR after the first deploy. After deploy
so I think looking at the left panel is expanded relatively well, and check it up the aortogram again, and if the severe AR present, we will do post dilation, but we don't know what's happening in the between two.
No, thank you very much. Any questions about this case?
You see, there's a waist there and there is some under expansion on the wall. So they put back the wire and the balloon.
Yes.
The brain, different leg,
Yep.
different leg. That might have something to do with this.
Yep. Yep. But nevertheless, good result at the end. You knew what happened and you put in the second valve very expeditiously and saved the day. So well done.
Okay. So I think we are presented the 7 consecutive case. Most case was very interesting, and we're gonna finish and that is the best TAVR case session. Thank you. Thank you.